This is AP Med. My name is Andrew Poveda, and today we are interviewing Dr. Correa. He is a neuroendocrinologist, and currently he is a huge person in mentorship, education. He's a clinical professor, and most importantly, he's involved in a bunch of societies and organizations, one predominantly being the American Medical Association, where he's a specialty chair for international medical graduates. Dr. Correa, do you want to introduce yourself for us?
Yes, how are you, everybody? My name is Ricardo Correa. I am an endocrinologist by training. Um, I am an international medical graduate, so I did my medical school in Panama, the University of Panama, and then after that, I came for postgraduate medical education to the US. I did my internal medicine residency at the University of Miami, and then my fellowship in endocrinology at the at the National Institute of Health in Maryland. And after that, I had been in certain part of the country. I was at Brown University and then at University of Arizona. And most recently, I have been in the Cleveland Clinic as the Pro Fellowship Director for the Endocrinology Fellowship. I also work with the medical school and do other things as Director for Patient Belonging and Outreach. So it's a real pleasure to be here with all of you sharing uh, insights and things about healthcare systems.
Great. Do you want to tell us a little bit more about yourself on a personal level, like who you are and your background, cultural wise too?
Yes. So, well, personal level, I am originally from Panama. So I did, as I mentioned, everything in Panama until I came to the US for postgraduate medical education. I identify as Latino. I am very involved in Latino groups in the US. I am married with two kids. My son is 12, my daughter is 8, and I play the saxophone, not so much later because I'm very busy, but I try to do that, and I like education, and I try to teach as much as I can. I dedicate my volunteer time to serve underserved communities, especially trying to provide some healthcare issues with the underserved communities. So that's a little bit of a personal of me.
So, what inspired you to pursue medicine in the first place?
Yeah, so I have a unusual story because I really started when I was a kid,
Hmm.
and I know that many kids always think, "Oh, I want to be a doctor," but I really started as a kid where I wanted to become to help others. And I always had this thing. My mother said that I always wanted to become a doctor or and a singer. I think that I didn't have the privilege to become a singer, and I didn't have the voice, but at least I continued to pursue that interest for medicine. When I was around 13, 14 years old, I had a delayed puberty. So then I went to an endocrinologist, and then for me, it was fascinating how they figured out how to fix that and using hormones and access. And since that time, since I was 13, 14, I became in love with endocrine. I thought that hormones were the way of the cells to communicate. And I just wanted to pursue that in my life. So really after that, I just wanted to go to medical school to become an endocrinologist. And I did internal medicine to become an endocrinologist. And finally I became an endocrinologist. So really, since I was a really little kid, I didn't see myself in any other area that was not in medicine to try to help others. I remember when I was in high school, I tried like, let me see if I like other things like law school or things like that. And nothing was fixing me. I was just fixated that I needed to pursue something that can provide care for others, but also that can provide science and advanced research. So medicine was the perfect combination for that.
Okay. Yeah, I tend to ask people the question if medicine didn't exist, what career would you have chosen instead? But you seem really
Yeah,
focused on medicine. Yeah, unless
I
maybe a
don't know
singer.
what. I don't know. I can tell you, I like politics.
Mhm.
So do something related with trying to create policies and things like that. I probably would pursue that. But also in medicine, you can pursue developing policies, healthcare policies, and all of that. So,
Yeah.
but really, if I didn't choose medicine, probably law will be the second option. It was not even in the higher level, but probably that will be a second option for me.
What have you done so far in your position as the International Medical Graduate Chair to help out international medical graduates and more importantly, enact policies and laws of that sort, not just in the AMA, but in general? How have you done it? Is there other conferences and other policies you could talk about recently that have been done that have piqued your interest as well?
Yes. So one of the things is that being involved in organized medicine is something that is my passion. And when you're involved in organized medicine, many of them make you develop that interest in policymaking. One of them being the American Medical Association, and I have been a member since I came to the US in 2010. I was the chair of the IMG Governing Council 24-25.
Mhm.
Oh, sorry, 2023, 24. So right now I'm just a member of the IMG section. I'm part of now the Council of Medical Education. So see, if I think back, what are the things that we have achieved in the International Medical Graduates section? It has been multiple things. One of them is we need to make understand others that international medical graduates are really physicians that are trained outside the US, but that they provide care for the most important people or for most underserved people in the US. And we need them because these are the physicians that will take care of approximately 70% of rural America, and 25% of all the physicians in the US are international medical graduates. And if we don't understand this, we miss something. We miss the part that really these people
Mhm.
are the ones that are helping our US citizens. Um, Things that we have passed during all this time as a section has been, for example, uh, uh, um, trying to expedite process in visas, trying to
Mhm.
equiparate the same US medical graduate and an international medical graduates so that there is no difference or no discrimination. Because sometimes in the past, was international medical graduate were considered second-class citizen. So we are trying to pass policies that make the same US medical graduate and international medical graduate at the same level. Definitely not only working with the American Medical Association, but also working with other organizations like Intel, that is the father of ECFMG, that is really the dean for the international medical graduates, and trying to foster international medical graduates, talking to programs directors about the importance of having international medical graduate in your program. What are the difficulties that an IMG suffer? What are the things that IMG can bring to the table? um, how to streamline the process for IMGs, all of that kind of things that sometimes is difficult for non-IMGs to understand. We have been trying to educate people and try to make aware of that. Simple things, for example, for us as an IMG, when we come to this country, is like we don't know what is a social security number. We don't know what is a driver license because it's different from country to country.
Yeah.
And then trying to educate people here and create programs, wellness programs that make these IMGs understand all of this healthcare system in the US and make the US understand the importance of the IMGs has been part of things that I have done during my career in organized medicine and in other organizations outside the organized medicine ones.
So, would you say that being an international medical graduate yourself, you graduated from the University of Panama. How important would you say it is that someone like yourself, an international medical graduate, somebody who's experienced it, that experience of being an international medical graduate and going through the system that you're advocating for, how important is it to have people fighting for the positions that have gone through that experience? And how was your experience has it back then compared to how it is and how you're trying to change it now?
Yes. So one of the things we need to understand is, for example, um, to be an international medical graduate and to obtain a residency in the US is not easy. you have to go through all the system and you have to go through the all the steps, all the USMLEs
Mhm.
and the match. Approximately the match percentage is 56, 57% to non-US citizen IMGs. So, so it's more than one out of two. When you enter to the system, of course, there are things that are some barriers that other people would not have.
Mhm.
One of the barriers is the accent and the language. Even though you can know English, it's not the same that when you are in the US that you just speak English. So that's a barrier that I feel that when I came to the US, even though I was in a bilingual school there in Panama, I have to like that it happened to me like the accent and it was difficult but other things that not understanding entirely how the healthcare system work in the US is different from country to country. So it's different how you want to help some patients, but there is no insurance. There's limitations that make you a little bit difficult to do the things that you want. And also the timing sometimes it's very restricted timing and the billing and all of that kind of things you need to learn. Electronic and medical record is something that, for example, in Panama we didn't have when I was there.
Oh,
Now they have it, but when I was there, no. And in the US, is everything in electronic and medical records.
yeah,
So it's a shift besides the culture. Culture in Latin America is a little bit different than in the US.
definitely.
We have to understand, for example, that physicians in Latin America are more into the physical exam, into the conversation with the patient. Physicians in the US are a little bit more on what are the labs, what are the imaging studies that you need to do, and a little bit less conversation. So things like that, how to adapt to the new system, to how to acculturate to the new system. But saying all of this, you do it. You learn, and not, right now it's the past for me. But trying to make the next generation understand these kind of things is important, and trying to make their life a little bit easier. Discrimination happen very frequently, as I mentioned, because of the accent, because of the color of the skin, because of all the things, because of the immigration status now. So all of that kind of things are certain are important that probably a U.S. medical graduate will not suffer, but as an international medical graduate, we need to overcome. And it's especially needed for the Latino community to have physicians that looks like them. And then if we think about it, only Latino physicians are only approximately 5.66%
Yeah,
of the physicians in the country. But the Latino population in the US is approximately 20%. So we are less than the population in general. And we know for many studies that a person, when they goes to the physician and they looks like them, they feel much better.
yeah,
So how can we do it? We can do two things that are happening at the same time. One is to prepare more students that wants to become physicians that identify as Latinos. That will take some time. There is a study in from California that if we start preparing right now a lot of Latinos students to become physicians, it will take probably 75 years to equiparate 20%.
wow,
There is another way where you can bring international medical graduates from Latin America that wants to come to the US and practice in the US. And then you can have that balance, well, where you can have some uh, Latinos IMGs treating Latinos in the US. So these are the two ways, and I think the two ways go hand by hand. We need more Latino students here that want to go to medical school. But meanwhile, we get to cover that gap, we can use IMGs. So I was still very privileged when I came to the US, and my focus in the clinical area has been a lot trying to help the Latino communities, creating programs, for example, I am an endocrinologist, so how to improve diabetes in Latino population with acculturation. So that's the main problem. It's not just only the language, but it's understanding the culture. So if you tell a person, do not eat rice or do not eat corn,
Mhm.
that's not going to flow because this is part of our culture. But we need to adapt and say, okay, now instead of eating this amount of corn, eat less, but combine it with proteins and things like that. So you need to understand the culture to say the kind of things. And the only ways that understand their cultures are us, Latinos. So
Mhm.
that's why it's so important, for example, in my job, as a person that really cares about health equity, in my job to have Latino physicians that can understand the culture and that can create programs and projects that will be adapted and acculturated for the Latino community.
Yeah, cultural competence is definitely one thing that you need to have, and it definitely is lacking. I didn't even know about the study, the California study. Maybe you can send that to me after. But
Yeah, well,
I didn't even know about that California study. You said 75 years, right? That's
75 years
that's
to keep it
massive.
just to the 20% that exists right now. Remember, 75 years right from now, we will not have 20% of Latinos.
It would
We
be a
will
lot
have
more.
probably 45% of Latinos. So,
Yeah.
so it's, but just to keep it at 20% that we have now.
Yeah. Okay. So on the note of cultural competency, so you're the assistant director for DEI at Case Western, right? How is it in that role? How would you describe that role and the impact you've had during your time at Case Western?
Yes, so well, I'm part of a so we have a department in the in at case that is under the assistant dean of the DEI. Changed the name now, community outreach, because of the
Oh,
political environment.
okay.
So
Yeah.
it's not DEI anymore. You know that sometimes we cannot mention DEI,
Mhm.
but the role has been my main focus has been on mentoring and creating a mentoring program for at the beginning prior to this government was for underrepresented minorities,
Mhm.
and after this we have to change it to everybody just because there was this issue against DEI, but the mission and mission continue. The mission and mission continue is to foster underrepresented minorities so they can feel comfortable to go to medical school, and from medical school to continue and then thrive during medical school. So creating some mentoring, putting with some mentors that looks like them, so that they have gone to the same process probably,
Mhm.
and then that they can help them. Definitely has been, and I did this also in my prior institution at the University of Arizona, where I was the director for DEI for graduate medical education, and working in that office of DEI, we really focus on um, pathway programs for college students so they can go to medical school, even going to high schools, even going to middle school, showing those kids that we were Latinos and that we were physicians so they can do it. Because sometimes what happened, I was in Phoenix, so a lot of Latinos. So what happened is that you never think that you can make it because you don't know anyone that has make it and it's like you.
Yeah.
So if you show them, hey, I am a Latino and I am able to become a physician, you are also too, that will stimulate more and more participation of students, high school, middle school students to go to at least college and then medical school. And then also teaching the parents, because sometimes and in the Latino community, we have to understand that the parents most likely came to work in the US and they
Mhm.
have zero idea of going to college, zero idea of what is college, zero idea of what is going to medical school. They just came to work. And the students, if you don't have a parent that understand what is the future, the students will never think about that. So you have to divide it into one, how to tell the students that they can do it. And usually you have to do that in English, and then how to tell the parents what is a college, how can they enroll their students in their kids in college
Yeah.
and university, and you have to do that in Spanish. So because it's different generations and all of that. And this kind of programs were very successful, continue to be very successful in Arizona. I think that we did with the team there a very very good job trying to support all of the ethnic group, for example, Latino Medical Student Association, LMSA, or SNMA, the Student National Medical Association, or a PAMSA that is for Native Americans. So all of that kind of things, nurturing them and try to support them. The same thing happened at Case Western, where trying to support and be mentors for the LMSA and SNMA and trying to help them when they come with projects. For example, right now I'm working with one MS1 student that she wants to do acculturation of food for patients, for Latino patients. She's part of LMSA. And very interesting because she wants to start teaching Latinos how to cook healthy using their own food.
Oh,
So it's
that's
not it's sometimes that's why when you go to a doctor and the doctor doesn't understand, it says, you have to eat healthy. But eat healthy is different from group to group.
mhm.
In a Latino group, you can say, okay, instead of eating rice, let's use quinoa. Uh, let's use other type of
Parts.
condiments.
Yeah.
So that kind of things help. And this project and this came from a student, and we are working right now to get some money to put this project into place. So all of that kind of things, to tell you that really there is an investment from institution, in this case Western, to realize things, to move forward, what in the past we used to call DEI, but to move forward these kind of things that is outreach to the community,
Mhm.
and and foster that community where they are located. Yeah, yeah,
Yeah.
Case has been very supportive of all of these groups. Of course, you always need like the power or the enthusiasm of the students. And just to give you an example, how students are so powerful, when I was in Phoenix, there was a clinic that I was volunteering
Yeah.
as the medical director for underserved, undocumented patients. um, Really, I wanted to bring the students so they can have like a free clinic, and student free clinic comes. But the
Yeah.
problem was that usually it was very difficult. No, yes, no. Until one day, one student, she was an MS3 at that time. She
Yeah.
said when she was in college, she was helping the clinic,
Mhm.
and she decided to go back again. And when she met with me, I say, yeah, I have been trying this for 2 years, but probably if you talk to the dean, probably it's easier. She went to talk to the dean,
Mhm.
and 2 weeks later, students were going to that clinic to help.
Nice.
So the students, I always say the same thing. Students have a lot of power, more power than faculty. If the students create something and have a passion and they are very enthusiastic on that, it will be achieved. The school always listen to them.
Okay. Yeah, that's good to hear that students could really make the change, especially
Yeah.
if they try. It's all about having the effort and like goal in your mind. Like I want to do this, it's gonna happen. So,
Yes, for sure.
yeah. Okay, so earlier we were talking about mentorship a lot in programs like community outreach to help out and try to get ethnic groups to like higher education and like and things of that sort, right? How do you design mentorship programs that work? Because you said they've been really, really effective, but is there certain components of these mentorship programs that make them work effectively the most?
Yes, so it depends a lot on the institution. What
Mm.
we have tried here at Case was a more formal mentorship program through a system called Cooper, where you have like it's a system, you have an app,
Yeah,
and in that app you can track the your meetings with your mentor. There is topics that you can talk about each month. Many things, very structured type of mentorship,
yeah,
and that has been giving a lot of results in the sense that people feel that, okay, I have to arrange a meeting for this month. So you meet at least 1 or 30 minutes or 1 hour per month. It can be in person or virtual. Then there are topics that you have to discuss that they finance, how to work-life balance, things like that.
Mm.
So that kind of mentorship, I think that works when it's very structured, works a little bit better. I have been in other mentorship program where it's less structured. So they just pair you with someone
Yeah.
and then it let it go, like
Oh.
whatever it happened or not. And then sometimes if you don't track, if you don't pressure the pair, the mentor and mentee, if you don't pressure, then you don't get really good results. So I really like more the one that is a structural mentorship where you have to report, you have evaluations, the mentors evaluate the mentees evaluate the mentors, and at the end of the year you have an evaluation of the program to see if it works or not.
Mm.
Of course, the structural one take more time and cost more, like the Cooper platform costs a lot. But if the institution is willing to invest, it's a great option to have a structured mentorship program.
It's Cooper with a Q, right?
Yes,
Okay,
correct.
I've heard of it
Yeah.
then. Yeah, yeah,
Mhm.
yeah. Well, of course the system isn't perfect. I'm not sure maybe if you know how it works. I know it's AI, but how does the matching system work? Like how does the algorithm for the AI work? Do you know?
I don't know exactly the algorithm, and different programs, different Coopers have their own algorithm.
Mhm.
So definitely you ask questions and for mentors and mentees,
Yeah.
and then you prioritize. You can do that. You prioritize what do you want to do first and second and third. For
Mm.
example, in our case, we start prioritizing what was the um, race ethnicity that the person wanted to be paired with, and what was the gender that the person wanted to be paired with. But you can move, okay, you can move what are the interests of the mentor and mentees to be number one. So you can move it, and then the algorithm will start pairing like that.
Okay. Yeah. I was just curious. Yeah. All right. Okay. So as a clinical professor, so you're teaching, researching, and you're in the clinic, right? So
Correct.
how do you
Yeah.
manage all three of these without losing that ambition and that goal and your sense of purpose?
Yes. So there are certain things. So when you mention like clinical professor or professor, these are not necessary. Everybody have to go to the medical school and give lectures and or classes in medical school. When you're affiliated with an institution, if you are in the hospital and
Yeah.
you see students with you
Hmm.
in the clinic, or you have residents and fellows, you also have that affiliation. So in
Oh,
my case, I do both. So I do run a course for third year medical students. It's called longitudinal didactics. That is the health science system curriculum for the third year medical students.
oh,
But that's something that I do with a medical school. But also involving in education is because with me, students come and rotate
hmm.
in the clinic when I'm doing my clinical work, and also residents, and I'm the director of the fellowship. So all of that is education, and because it's education, you have an affiliation with the institution. In this case, we have a College of Medicine called Lerner College of Medicine that is under Case Western, but it's from the Cleveland Clinic. So that's that. And then you balance, it's very difficult sometimes to balance clinical time, research, and education. And it depends on how much protected time do you have and all of that. The main driver as a physician will be clinical. It will be seeing patients. That's most likely what will pay your salary. But then on top of that, sometimes you can buy time with grants, with research grants
Hmm.
that can protect your time from clinical, and with educational grants that can protect your time from clinical. And then you have some balance there. Definitely in medicine, there is no like 40 hours a week. That's
That
not true. Sometimes you have to invest during the weekend or after hours, for example, in research during the weekend or after hours in some educational programs. The only thing that keeping that 40 hours will be clinical. But even in clinical, when you have patients that message you, you have to do probably after hours they responded the message. So really it's a balance, and I think that with time you start discovering how can you balance, but definitely will not be only 40 hours a week.
Wow. Okay. This is the first time I'm hearing of this. So, if you're, it's not just 40 hours a week. If it's 40 hours a week, it might just be the clinic, and it might not even just be that because maybe you get a call or text from a patient. That's a lot. Yeah.
Correct. Yes. So it's the 40 hours a week is if you probably if you just want to be a clinician. If you just want to be a clinician and you don't do anything else,
Mhm.
probably can be 40 hours a week. But if you were to be in academics
Yeah.
and doing some education or research or both, it sometimes extend more than 40 hours. Sometimes you working on weekends, or sometimes you have to finish a paper after hours.
Yeah.
So it's not exactly the 8 to 5, Monday to Friday.
What's one question you wish more pre-meds asked you about?
One question that more pre-meds ask me about is how is the life of a physician? And how can you balance work and social life? I
Mm.
think that not everybody asks that question. Everybody want, oh, yeah, I want to go to medicine. But I think that you should start focusing on how can I balance my work and my social life, because social life is as important or more important than work.
Yeah,
And if you don't and you don't learn how to balance that, you are going into a burnout for sure.
definitely. Yeah, burnout's a big one. I hear that all the time. Yeah. Um, so very current thing, but what's one thing you're currently proud of? It could be an achievement, an award, anything.
Yeah, I think that I'm there's so many things, but I'm very proud of the work that we did when I was in Arizona to foster Latinos in underrepresented areas in Phoenix. So being the medical director of PASH Clinic, where we help people that they were undocumented and they didn't have insurance, and we helped them during COVID time with everything and the vaccination. That is one of the things that I'm more proud of.
So, what's something that Case Western does really, really well as a medical school that you wish other medical schools adopted?
Yeah, I think that one of the things that that Learner, because in case we have two medical schools, we have one Learner College of Medicine that is the college that is the Cleveland Clinic part, and School of Medicine that is the Case one. So it's two medical school
Big
in
one.
one university. So I think that I can speak about Learner, and what I really like about Learner is that there is a mandatory fifth year for research. And
Mm,
I know that this is uncommon. One of the things is that Lerner College of Medicine is tuition free. So it's
uh,
being paid by the Cleveland Clinic. So it's 5 year medical school, but paid by the Cleveland Clinic.
yep.
So it's not a big school, it's 32 per year. So it's not a big school,
Yes.
but they pay your tuition. And I think that that's a great model because medical school is so expensive. With the condition that you have to focus a little bit of a science. So do a fifth year of research. Compare with other medical schools that are 4 years, but very expensive. And the research is immersed in those 4 years. And the second part, I think, is the small group sessions that they have, that because it's a small, at the end, it's a small college, everybody know each other. And that's great.
Yeah, the smaller, the better sometimes. Yeah.
Yeah. More familial.
Yeah, yeah, exactly. Okay. So if someone were to ask you to pick like one sticker to represent yourself, what would you pick? It could be like a hobby, something really personal, anything in general.
What's sorry, what was it? One sticker
Yeah,
or, or a phrase
or
can be
yeah,
a
a
word.
phrase. Yeah.
I think that for me, sky is the limit is my phrase. There is nothing else that can prevent you to be whatever you want. So the sky is the limit. So you can achieve anything in life.
I like that. Yeah. All right. And last question. So if if someone were listening to this and they didn't listen to it, the single word you said, what would you want them to remember you by?
I think that I would like to remember that if you are in this process of getting into medical school or in that process, everything, as I mentioned, you can achieve anything. Do not put barriers. And if you fall, stand up and continue. Many things that I have achieved in my career, I didn't achieve the first time, not the second time, not the third time, probably the fourth, the fifth time. So just fall down. Do not get disappointed. Probably that was not the right time for you. Stand up and apply again, and that helps you in that. If you are thinking on making changes, sometimes you don't have to think of making, oh my god, I need to make change in the entire country. The only change that you need to make is in your environment. You just change your environment, you change everything. So we have that dream like, oh my god, I need to change the entire thing, and that's not true. I realize that, for example, when I just focus, for example, in the Latino community in Cleveland. And if I can contribute a little bit to that, that's a big change in the world. So you don't have to be huge projects, small projects, trying to whatever, focus on that, and you can achieve it. And then you will change. Really, you are changing the world.
Like you said, the sky's the limit. So, yeah.
Because, yeah.
Okay. This is AP Med. My name is Andrew Poveda, and we just finished interviewing Dr. Correa.